For the people who have been practicing for a while, this is really sort of whiz-bang brand new stuff. The introduction of Biologics, first in '98, and first in rheumatoid and Crohn's disease, and then across diseases. And this is where we are. Actually, this isn't even where we are. This is already outdated. You have so many biologic agents that target distinct aspects of the immune and inflammatory responses that we're just blessed with the opportunity to use so many different weapons in our attack of the immune system and the inflammatory response in patients with rheumatic disease. So here's a list of them here, and we know of some that work across diseases, like the TNFa inhibitors are very efficient for a number of conditions. Some seem to work better in rheumatoid arthritis and not so well in other things. For example, IL-1 and IL-6, not so efficient in ankylosing spondylitis. On the other hand, some seem to be better in ankylosing spondylitis and psoriatic arthritis, like the IL-17 inhibitors. Then, completely different perhaps, B-cell targeted therapies, although there's some overlap, and even bone relevant molecules, of which there are several, which handle a different aspect of the consequences of those diseases.
So this is really dovetails well with what Ian covered this morning, where he showed us a lot of great mechanistic stuff, but really concluded that to get to the better answers and better outcomes in RA, we need to look at the right patient, the responder, and the responder to one of these drugs. And then we'll know what mechanisms are involved in those particular people, and then look in the right place, being the synovium. So again, historically, this was what? Bench to bedside, and he's sort of suggesting the opposite.
Yeah, and I think that's what many of us are starting to realize. And if you put this together, and this too will be outdated relatively soon, but here, looking across a number of inflammatory states, and here you see cytokine-targeted therapies and other kinds of therapies. And we really are learning bedside to bench. In fact, I think it's not going to be too long before we start talking about diseases specifically on how they respond to particular therapies. And there'll be IL-6 responsive rheumatoid arthritis. There'll be subsets perhaps of psoriatic arthritis defined not only by what we see in terms of the skin inflammation and the joint inflammation, but also how they respond to therapies. And here you see the JAK inhibitors are just now entering this, and they're another layer of complexity, because as we've heard, you can discuss all day long about what the different specificity for JAK1, 2, 3, and TYK2 might translate into. And as we go across diseases, you might bet that maybe different JAK inhibitors might be more or less efficient in different conditions. This is our history. Anything that's surprising that we still can't explain that we've learned just from the bedside to bench approach?
Well, how disappointing the results of IL-1 inhibition has been. While it's approved for RA, there's only a subset of people that do, and it's a subset of the systemic JIAs and autoinflammatory diseases. It's now showing up maybe in multiple sclerosis and others. But I think what is interesting about this slide, which comes from Georg Schätz and Ian's article, I believe, is that
it started there. I had to update it.
Well, that's it. We keep changing it
all the time.
Right. So we're changing those gray boxes to they're different colors based on as the information rolls in. So to me, that's the next most surprising part of this. And maybe at some point we fill in all these boxes with the right answers, whether they definitely don't work or whether they clearly have promise. So, but this is where we're going, right?
And talking about personalizing it, and then this is a slide we stole from a review in the allergy literature, the Journal of Allergy and Clinical Immunology, and they're wrestling with the same things. And I think at this conference over the years, Lenny has had specialists in GI and neuro, and they're sort of wrestling as we are as well. So we have what we see in the clinic, and we think we put these constellation of signs and symptoms together and think that that's a condition, but it's really a group of conditions. That's true for RA, it's true for SLE. How do we approach that? Will we ever get to personalizing? Well, this is sort of their take on this, and that is taking the individual patients, of course, the relevance of the microbiome, you see that's in the middle of the red box there. Microbiome presumably important because of the changes it can induce epigenetically. And what influence that has then on the development of the signs and symptoms, eventually getting us the clinical expression. But I think also in there we have to add the response to therapies, which kind of seems backwards. You have to try the therapy and know if it worked, but that is going to give us, I think, important information about what's going on with that patient. And then, of course, in an iterative process, we will need to learn more about that patient to know perhaps how best to go further into therapy. And the more we learn this for groups of people, helped by the ability to think in a not strictly linear way, as we always do think that A causes B causes C, but in a more systems biology approach where you take lots of different influences and see that they can affect each other in a non-linear and almost a chaotic way. And I think this is there's nothing firm here we could take to the clinic with us tomorrow when we're seeing patients, but this is perhaps a way we're going.
Sounds very similar to what Ian said at this morning's conference lecture, and Artie was still traveling when that was going on, so you're really dovetailing well. This is an example of how we could use this, right?
Yeah, and this is an example. This looks at the metabolome. So for years, immunology was based on proteins. Proteins, just like T cells are the brains of the immune system, T cells are proteins are the most effective soldiers. We've ignored other metabolites, and I think now we're seeing that they actually can be very powerful. They can be very powerful, certainly in an epigenetic way. This was a study done by Monica Guma, who looked at samples that we had had of patients treated with Rituximab and saw people who responded or didn't respond, and then looked at an extensive metabolic profile of non-protein mediators, potential mediators, and did principal component analysis to try to separate out responders from non-responders. So, and here you see there is, you can do that. Of course, you can always do that with these rigorous types of computer-driven analyses. You can always separate out something that correlates with response and non-response. But I think this is an area that we've ignored for a long time, and we're seeing much more interest in now, specifically because the technology is caught up so that you can do these kinds of analyses easily on a lot of samples, as we've been able to do pretty rigorously for protein samples for some time now.
Okay, so this was one of the goofiest abstracts from ACR, but still one of the ones that people like to hear most about. It's the refrigerator study. You know it better than I do.
So yeah, we're talking about biologics and across diseases for Dr. Calabrese, and this was presented at ACR, and the idea of it was that they were thinking of taking the biologic samples that patients had, and if they weren't using them, say, hey, bring it back, these are expensive, let's reuse them. And to do, as the first test of whether or not they could do that, they gave these little temperature devices. Anybody does clinical research, the temp tell, to see if the drug was kept in the ideal circumstances. So drug absolutely shouldn't freeze because that can degrade it, and you shouldn't put it in the microwave. It shouldn't sit on the counter for 3 months. So they gave these little temperature devices, told the patients exactly what to do with their biologic when they went home, told them exactly what not to do, and then when they got back, here are the data. Basically, nobody got it 100% right, even though they were told to. Some of the people, it was above 8 degrees for a half hour or more. And you see maybe that doesn't matter so much. The proteins may well be stable. We don't know from these data about the actual effectiveness of this. Much more worrisome is those that froze, and crazy are those that froze and thawed. It's like, what the heck were you people doing with your samples? And I think it just, sometimes we get so caught up in the mechanism and the kind of cool immunologic stuff we like to think about, but the patients are the patients. When they're not doing well, the first 7 questions are always, are you taking your medicine? Really? No, are you really taking your medicine? And I think silly practical things like that with these elaborate, very fantastic agents are going to matter. So I thought this was a kind of an interesting foray into this, something we don't ever think about.
And beware of the CRISPR. The CRISPR is where a lot of people put their medicines, and it's colder there, and that may not necessarily be a good thing. Mike Holler's talked about treatment interventions and preclinical. This is the data that was presented at EULAR on what's called the PRAIRI study. It was more or less like the research he mentioned, that they recruited these people from a fair. The 82 of them, and the vast majority of them were first-degree relatives, and to be in the study, to either get a single dose of Rituxan Rituximab or placebo, you had to have arthralgia and be seropositive, and then either have a slightly elevated CRP or subclinical synovitis. Not many had the ultrasound synovitis, most were the CRP, and they randomized 41 and 41. One patient dropped out, and you can see what happened to those people as far as the onset of developing arthritis. And the Kaplan-Meier plot showing you that those who fall off, the ones who develop arthritis, with less development in those on rituximab. A little bit of a delay there. The question is whether or not you believe that to be clinically meaningful. Again, it is only a single intervention, and they did show that the time to develop arthritis was longer, 16 months versus 11 months if you were on rituximab. There was a few more SAEs, 11 versus 3. It was not statistically important, but it was a little concern there. So this is important, and it's the first randomized clinical trial in preclinical RA with an outcome. Of course, you'd like to see there's an 18-month follow-up on these people. You'd like to see what happens to people over time, if it does change their course. We saw in the PROMPT study when we used methotrexate that although it looked great at 18 months in a subset, it didn't really pan out over 5 years. So we'll see what happens. And as he mentioned, there are similar trials like this going on right now with abatacept and hydroxychloroquine.
Yeah, I think it's a small study, simple concept, but I think it highlights many of the discussions. I know Mike is a real big believer, and he thinks we're way behind. He thinks we should be jumping in very early, and if you say, well, rituximab is one of medicines that could have side effects, and if you have a potential side effect and you didn't have the disease, you're never going to get the disease, then that's really not good. So what's the right agent? The study doing Plaquenil has the benefit of it's hard to argue with giving someone Plaquenil, even if they were never going to develop rheumatoid arthritis. Tom Huizinga, with his PROMPT study, they just did a reanalysis of that and showed that, because that study was done a while ago. Remember, then they used the old ACR criteria. If you look at only those people who fulfill the new criteria, it looks like it's actually better. It looks like methotrexate does much better preventing it, and it lasts longer. Of course, that's, if you do the same thing and go back and change the data, the Padres actually won the World Series last year. I don't know if you know that.
Or belimumab works.
I think we need to go cross something off your disclosure list there, Jack. But this is what do you do? And I think we all get patients who come in and say, my sister has rheumatoid arthritis, and you're like, yeah. She's like, no, she's on a TNF inhibitor, been there, has, blah, blah, blah. And I have a high ACPA, and my knuckles ache, and you examine them and say, I don't find much now. Would you give her methotrexate?
Well, he led with a question, and most of the audience said bring them back and follow them, whereas I think in practice, much higher percentage of patients are getting treated with the hope that you might be doing something beneficial for those with arthralgia. This is an interesting study. Tell us about this.
Yeah, this published earlier. It's Jeff Sparks did analysis, claims data, and we've seen so many studies, purportedly biologics versus triple therapy, and there are certain people. Is Jim here? No. Oh, okay. There are certain people who will say that triple therapy is every bit as good and it's much less expensive. Are we listening to this? So this is you all. This is what all of us are doing from July of 2009 through 2014. All these studies being published saying biologic is not necessarily much better than triple therapy. This is how it's being used. And here in the quotes up top, this was their take-home point. So despite recent reports published, you ain't doing it. So what is wrong with you people? Why are you still not using triple therapy? Why are you using biologics 8 times more than triple therapy?
Well, Ed Keystone's here. He was part of the study, too.
Sorry.
So be careful.
Yes, Ed wants to answer the question. Ed said he agrees with the election of Trump. He wishes they had Trump in Canada, and then something about sulfasalazine.
But in Canada, what you do is, because you have a 3 DMARD requirement, most people go on triple DMARD so that you have the option of using a biologic earlier than going through them serially.
Forced use. In other words, we have to have at least double therapy minimum. So obviously you throw in a third in order to get the biologic.
Okay. Makes sense. I think a lot of people do this. The other, I mean, to be fair too, there's obviously a big marketing machine, behind biologic use, and there aren't enough people out there really fanning the fires of triple DMARD therapy, at least being used initially. So, but again, that is the data. That's what people are really doing. So it's a little bit concerning. The C-EARLY study was a study of early RA patients who got certolizumab methotrexate, and for those who achieved a low disease activity, they were then stopped, or they reduced, or they stayed on their standard doses, and this is what happened to them over time.
Yeah, and I think it's interesting. We're going to talk in a subsequent lecture about tapering as a specific topic. And to me, the tapering issue, it's glass half empty, half full. You look at the data and you can interpret it, I think, based on what you sort of wanted the data to say. But in this case, if you look after the middle of the graph, after week 52, it looks like both curves really do pretty well. Certainly, they remain in low disease activity on average. It looks like those who remained on biologic did better. But the spread seems less than it's certainly been in several studies that we've seen of other biologic agents.
But that could be an issue of the graphics here. This is a mean -28 of 1.87, and this LDA is 3.1 for one part of the group. So the idea is that it doesn't look that bad here, but there are people that do get worse when you stop their therapy, and that's been seen almost in every study. And
one difference in this study than the others is the methotrexate was very aggressively dosed. It's been typical to try to get to 20, and the average is usually 17, 18, 19 milligrams. This one went further and faster, and maybe it was the stronger, faster use of methotrexate very early on that helped diminish the differences between the two of them, which again points us back toward optimal traditional DMARD therapy versus biologic therapy.
So it's a little bit like the PRAIRI study and a little bit like this hopeful study that was done by Professor Tanaka.
Yeah, and the Japanese have been looking at the idea of tapering therapy. It's a kind of this study. It's kind of a funky design, but the design is very important because it gives you, I think, important information later on. So it's methotrexate versus methotrexate plus a TNF inhibitor, in this case adalimumab, 6 months, then everybody gets 6 months of combined therapy. Then they discontinue, roughly half of them, or they continue the TNF inhibitor and then follow them out for a couple of years. So nice long follow-up. If you look at the graph in the middle, the glass half empty thing. So if you stay on therapy, you have a very high chance of still doing well, sustain low disease activity. But if you stop, you have a pretty high chance, 80 versus 95. The X-ray changes on the right speak not necessarily to the tapering, where there was less a difference, but where you started. So those who got the TNF inhibitor first, at 4 years, still had a very discernible benefit in terms of radiographic change compared to those who got methotrexate monotherapy first. So getting to the whole treatment paradigm, this, I think, would say, whatever you're doing later, hit them as hard as you can early, because that can have a sustained benefit. And as always with these studies, you can discuss what's the difference in 5 sharp units over 4 years, and when is that eventually going to correlate with the change in functional status by hack and those sorts of arguments. But I think intriguing data that I would say could support the idea of treating very aggressively early on.
So the X-ray image is that which we've seen in other trials where there certainly is a difference when you stop. There's a clear-cut hit to the radiographic benefits over time. The middle image, though, is better than most of the trials that we've seen. And is that a function of that population? Is that a function of how many options they had available to them, just without being in this study and whatnot? I think the middle trial, which is the clinical outcomes, is a little bit optimistic for my taste. But nonetheless, I think it is instructive. And it does support the idea that you could withdraw some therapies in some patients. So time for a question, okay? If you're on a TNF inhibitors, the question is really, when do you use a non-TNF other MOA biologic? And those are your options there. Number 1, you use it before you use a TNF inhibitor. Number 2, you use it after the first TNF inhibitor failure. Number 3, you use the MOA after the second TNF inhibitor failure. 4, after the third or more failures. And number 5, you use the other MOA after a JAK inhibitor. Answer now.
Did you have the gift card?
Lenny?
Do we have? Yeah. Jonathan already won. Sorry.
Then we split it with him later. So after the first or second, and that, you know, that kind
Before, look at before.
before is 14%.
Wow.
Yeah, well, that's aggressive. Those numbers, though, that's basically 85% are saying that they'll use it either after failing one or after failing two. The numbers previously, up till now, about 70% would go, certainly 75% would go with one, and then after that, another 30% would wait till after two. So maybe it's evening out, maybe it's getting a little earlier. I don't know. I think that's impressive.
Jack,
Yeah.
revoke that question and change the wording to when would you like to use or not?
Like to?
Instead of being forced to.
This is you want real world or you want fantasy world? Do we want to revote on this?
Are we voting on revoting?
No, we don't have time. Let's move on. Accelerate. Interesting in that there were a few studies that came out at ACR that were presented at ACR while they were being released into the literature. Elaine's precision study was presented at the ACR while it was in New England Journal. This one presented at ACR by Fleischman while it was being presented at the same time in Lancet. An early RA trial, I don't know what they were thinking, head-to-head, a TNF inhibitor versus a TNF inhibitor. Certolizumab versus adalimumab in standard doses, and they looked at a 12-week time point. If they did not achieve response, then they were re-randomized to the other drug. So you basically were looking at primary non-responders. You didn't have a response. And the interesting thing that you saw is the top graph here, that these are the real responses. 80% will respond to one drug or another. Now that's higher than ED's 60-40-20, but this is open label therapy. So usually you get a little boost in the numbers above what you see in a placebo-controlled randomized blinded trial. So there is open label therapy, but for those that were primary non-responders who switched over and now get the other drug, the response rate is less than 40%. So for those of you who switch from one to the second, might you do better had you switched to another MOA? You know, historically it's been said, if you're I say at least, if you're a primary non-responder, you should be moving on. If you're not, if you're a secondary loss or a toxicity issue, maybe it may be worth waiting around. I mean, how do you interpret this trial?
Well, it's difficult and gets to a core issue of study design. So you need to do something at 12 weeks because it was felt that you could not leave people longer. But I know, and we actually published this over a decade ago, that some people respond slow. So those people who stayed on, who went from one TNF inhibitor to another, who responded could be slow responders, not that they responded differently to one TNF versus another. I think that's absolutely the case. And I agree with you, this is the ceiling. This is the best a TNF inhibitor will do. If they had put a different mechanism of action in this study, this would have been fantastic. This would have been game-changing. If they put two, this would have been a landmark study, but they didn't. They did TNF versus TNF, so we were left with this. I think you can say that if you don't respond by week 12, you have a chance, but if you look in the bottom right, the ACR 70, that's what we want. We want people in remission. It's very, very low. So if you don't do very well in the first 12 weeks, the chances you're going to get in remission with this approach are very, very low. You may get an ACR 20, 40% of people get an ACR 20 eventually, but you're not going to get what we expect from therapy now.
So what you're seeing on those graphs, though, if people are plateaued at week 12 on ACR 20, they're still going up on ACR 70. I think that paper you did with etanercept was important, but realistically, I don't want to give the message to people that you should stick in there, wait for those last few responders. It's sort of like if I keep taking Spanish lessons, I'm going to get better in week 24 than I was in week 12. If I'm not good at week... Clara, KC, sure. But the idea is that you're looking for a minority when you should be moving on. And for those that do achieve that ACR 20 response with an extra 12 weeks, they're never going to become ACR 70s or ACR 50s.
Yeah, and that's what the graph shows. It's a very small chance.
So, I mean, I think this not only speaks to how you respond to a primary non-response, but also we should be shortening the window by which we're making decisions. I think 12 weeks is the absolute max. I would actually advocate for 6 weeks in most patients in the real world. So next, there are other head-to-head trials that have looked at this issue about other MOA use. The Orbit study was actually an early RA trial and it was published in Lancet, where you either did rituximab or a TNF inhibitor, and they had a lot of the same responses across the board. I'm just showing you the DAS ESR reductions in both groups, that it didn't matter whether you're using a TNF inhibitor or rituximab, a drug which most rheumatologists don't use for fear of PML, a 1 in 30,000 event, but it's a very good drug. It works great. This shows it works as well as the standard of care for most of you, which is TNF inhibitors. The JAMA trial was the same as our question almost, which is after you fail one TNF inhibitor, what do you use? Should you use a non-TNF or a second TNF? And here they showed that you had much better EULAR responses and LDAS, low disease activity responses at week 52. There were a number of other parameters where they were kind of equal and not significant from each other, but those two were significant differences. And then Curtis looked at what happens in a much larger group. I mean, he looked at thousands and thousands of patients and then coned down and matched them, and he compared MOA switchers to TNF cyclers. TNF cyclers are people who keep using TNF, and those who switch to an MOA after the first TNF. And he showed that the MOA switchers were more likely to be to persist on that therapy as a measure of efficacy. He has a way using claims data to get a surrogate measure of efficacy, which is multidimensional, but they obviously don't have joint counts and patient globals and stuff like that. It has to do with whether you start other therapies, use steroids, stay on therapy, et cetera. But there's a growing body of literature about when and how to use these other MOAs.
But not which one to pick. I think that's the issue as well. These have been, and the studies they're open, so there's confounders to that. But I think, yeah, you could make a case that you ought to think about a different mechanism earlier than we've been before.
Yeah.
Why was the cost less?
The cost less of the Rituxan?
On the last one.
Don't know the answer to that.
Yeah, and this is claims data.
Because it was
use.
multiple drugs. It wasn't just Rituxan.
Yeah.
It has been shown for Rituxan to be less because it's usually the one-time, once-a-year cost, except for some people like to do it every 6 months. But there were multiple drugs in there, so I don't know the answer to that. I don't know that he'd be able to tell either.
Jack?
Yeah.
I don't think it's been shown, as some have done, that if the patient fails a TNF initially, let's say within the first 3 to 6 months, that it's likely best to go to a non-TNF. But if you were a secondary failure, and there's data for that, that is you actually responded, let's say get to a low disease, and then you're doing well for 6 to 12 months, and then fail, that a second TNF may be helpful. We're actually about to do a study of that because there is data to support the concept of secondary versus primary failure in terms of using a non-TNF versus a second TNF.
Yeah, and I think that makes total sense. It's difficult, though, isn't it? Because those definitions are seldom pure. Certainly for us in the clinic in the U.S., whether or not people are a failure depends on how well they did, how they tolerated, how much it costs them, time of year, whether or not they're going to stay on a lot of other therapies. So finding pure secondary failures like our GI colleagues talk about, and that's why they're big fans of measuring drugs and anti-drug antibodies, that if you did well and you all of a sudden had less drug level because of anti-drug antibodies, absolutely makes sense to stay within the class.
So there are other head-to-heads. In 2013, the big splash was in ADACTA, tocilizumab, an IL-6 inhibitor versus adalimumab. And then now there are 2 others that came out in the last year, the MONARCH study with sarilumab and Secukinumab, 2 new, burgeoning, about to be approved in some places. In Canada, approved. Secukinumab is approved. And we expect those to be approved this year. There's going to be 3 IL-6 inhibitors on the market. And the question is this going to be a threat to how we use TNF inhibitors? And they looked in 2 out of the 3 trials, ADACTA and MONARCH, they were clearly superior. There were some things about SURROUND that were superior, but others that they were not. So if you looked at all the measures, there were very few measures, in fact, where it was superior. One was a change in DAS ESR at week 24, but other measures like ACR 24, 50, 70 were not. So why that is, not so clear. But nonetheless, there's enough data to suggest that IL-6 inhibition is a clear-cut competitor to TNF inhibition.
Yeah, we will have them, and then I think the still remaining question is inhibition of IL-6 receptor versus inhibition of IL-6, the cytokine. Is that going to make any difference? I think the efficacy, you can't compare them study to study. The side effect profiles sure do look similar. So I don't know that we'll be able to say clearly that one approach is superior to the other.
So the question is, what's it going to take to dethrone the TNF inhibitors? The IL-6, because they're going to gain popularity because they're going to not just have this new data out, but then they're going to have new indications that we'll also talk about. Certainly in large vessel vasculitis, maybe down the road in scleroderma. But I don't think we've done as well by challenging TNF inhibitors with triple DMARD or some of the other MOAs where clearly biosimilars, JAK inhibitors, and IL-6 are going to be major hits to the marketplace. And what's going to change how we use these? What needs to happen? Do we need more studies? Do we need more people saying how great they are? Or are we fine the way we are? I mean, most of us believe we're pretty good the way we are. We've got a lot of good tools. I might go to that IL-6 if I need it. I might go to the biosimilar if I'm forced to. But I think people are still very comfortable with their TNF inhibitor.
Yeah, and I think unfortunately we're going to be forced along some pathways with the introduction of new agents, with biosimilars. Costs are going to be a very big factor, and I think that may enter even more than it is now.
Trump care, right? That's the problem.
Wait for it.
Okay. All right, another question. What's the best tool to optimize therapy in patients not responding to 3 months, 12 weeks of a TNF inhibitor and methotrexate? Number 1, check drug levels. Number 2, check anti-drug antibodies. Number 3, you look for methotrexate polyglutamate levels. 4, change therapy, don't even bother. 5, call a gastroenterologist, they seem to know. Or 6, accuse the patient 7 times of noncompliance.
Let's see.
All right, survey says. Ooh.
Nobody calls a gastroenterologist. Wow. What the heck? Yeah, we know why, because they won't take our calls. Okay.
That's interesting. It's kind of I think it's what that accurately reflects what's going on. Very low level use of anti-drug antibodies or of drug levels. Don't you think there's data to support it?
Well, there's a lot of data. Actually, it's interesting. Their GI colleagues love this, but at the DDW last year, they showed this results of a study where they had an approach that was driven by TDM, they call it. That's the cool name, therapeutic drug monitoring, meaning checking drug levels repeatedly versus just seeing the patient in the clinic and acting according to what the doctor and the patient sorted out. And TDM was not superior. But they don't believe it because they believe in TDM and they get the levels all the time. They say the tradition is in GI that they only had a couple of drugs, so you really had to use them well because they had Inflammatory for the longest time, and that was it. Now they've got a couple of the TNF inhibitors, not all of them, but now they have other mechanisms as well. But they're still into this. And I think these data depends on what you think of it. I look at the graphs up top and say the change if you look at the different levels of certolizumab in the serum, this is in rheumatoid arthritis, you could say, well, maybe if you're very low, less than 5, you don't seem to have a good enough change in the DAS score as if you were in a higher range. But where does that higher range begin? The top right, you split them to deciles, and the bottom, where it looks like a difference, they're actually looking at sort of very low, and it looks like only if you have a very high level do you differently. So with most people, because not everybody responds to every agent, I think you'd be hard-pressed to make some decision based on this. You may want to do, as Professor Keystone has suggested, in a clinical instance where you know someone's taken the drug, maybe they're using it as monotherapy, you suspect anti-drug antibodies and low drug levels, maybe there's a utility there, but you'd be very hard-pressed to see it with the data.
Okay. Let's go on. Let's go back to the tapering stuff. This is I don't know this one as well as you do.
So this is in Denmark, in the jurisdiction around Copenhagen. They said that what happens now, and this has happened in Taiwan as well, that if you are in persistent remission, you see defined there, greater than a year, and had serial x-rays without progression, the doctors had to cut down on your biologic. So first it went down to 2/3 of a dose, secondly to half a dose, and at sequential intervals, 4-month intervals, if you're still doing well, you have to stop it. If you flare, you can then go back to the prior dose level, and you see the definitions for flare, an increase above 2.6 and a change from baseline, or changes on the X-ray or MRI. which are a little bit dicey because those are read blind, that there's a person at the site who's keeping an eye on the x-rays apparently. These are the data. So 71% of people who they tried this to flared and they stopped tapering. And this was the graph, and I actually talked to them at the ACR and I said, this doesn't look good. If this was your retirement portfolio, you'd be really heading for the door on this. And they said, well, what you're seeing though is this is lack of success. So this is, if you do anything, then you are lost. And if you look then at the bullet at 1 year, a third of the people are still on full dose. 20% are on 2/3 dose, 25% on half dose, 20% were able to stop. So they view it as a success from that standpoint to say, those people who are not on full dose, you're saving those doses of biologic and therefore saving money. They don't have the full x-ray data blindly read. They don't have MRI data released from this. They say the patients are not unhappy with it. I think the idea of tapering, and we'll talk about this much more in a subsequent lecture, but I think the idea of tapering is very interesting medically. It's super interesting immunopathophysically. I kind of hate that it's a political discussion that's being forced on us.
Well, I think that the graph on the right is really reflective. I think any loss of control is a negative thing because what you measure clinically is magnified even more so what happens radiographically. In multiple studies, and we showed that in an earlier slide. So I think this is a bad trend. And the ACR guidelines that just came out in 2016 or 2015 said that if you were an LDAS, you don't change. And most of these decision point studies where you make change are based on LDAS because the data is not very good. But if you're in remission and you're on combination, you could stop or decrease your therapy, but it never says to stop. Stopping is, trying to stop therapy in RA, which we know is a chronic, lifelong, progressive, horribly destructive disease, is probably not a good idea. So I think this data, which could be viewed as a way of saving money in a jurisdiction, is also a way of maybe causing harm. The AVERT study.
Let me keep going because I'll come back to that one later.
This one?
Yeah, we're getting
okay.
short on time.
Where do you want to go? So do you want to do this?
Nah, keep going.
Well, I'm going to look there.
Oh, do that one. Yeah.
Okay.
We rehearsed this, I promise.
An important study. We know that TNF inhibitors, when used, can avert bad cardiovascular outcomes, less heart attack, less cardiac-related events. Follows up on the methotrexate data that Fred Wolf and Choi proved that multiple studies show that the longer you're on methotrexate, the longer you're on a TNF inhibitor, better cardiac outcomes, save the heart, that sort of thing. Now with the introduction of IL-6 inhibitors and IL-6 and its relationship to CRP, its relationship to cardiovascular outcomes, would you see the same? This is a head-to-head trial of 3,080 patients who received either etanercept or tocilizumab and followed for 3 years. And they looked at the outcomes, the cardiac outcomes. The efficacy was, as you expect, about the same. They used the 8 milligram dose, and you could see across the board, the MACE, the cardiovascular deaths, the non-fatal MI, and mortality rates are exactly the same, suggesting that IL-6 inhibition is as effective in cardiovascular benefits as anything else. The only thing that they did see was a 9% increase in LDL in the tocilizumab group, and maybe a few more adverse events in tocilizumab versus etanercept. Numerically important, not statistically important, but and that may color your decision about whether or not to use one versus the other.
Yeah, I think this is incredibly useful data because these days everybody has my chart and they know what their cholesterol is and they know their cholesterol is higher. So it's very important to say there was this very large study which said, yeah, your cholesterol is up, but it doesn't appear to translate into a greater risk of a bad cardiovascular outcome. So keep treating your rheumatoid arthritis because that's very important.
So another important issue is now the introduction of IL-6 inhibitors in SPA and psoriatic disease. And this is a collective study looking at the adverse events, especially the colitis events seen in patients who did not have colitis going into these trials and how many developed Crohn's disease or ulcerative colitis with either being treated for AS or for PSA. And you can see the rates there. They're incredibly low. The rates are somewhere between 7% and maybe 14% higher. It's a very low incidence rate. The question is, how do you handle this in patients who you start on an IL-17 inhibitor? How much warning do you need to give them? There are some people who I've heard who say, if there's a family history of colitis, I'm not going to use Secukinumab, and to me that makes no sense at all because the event rate is incredibly low. I'm sorry, this is 0.14 per 100 patient years. That is, again, 1 per 1,000. And you're not going to give a potentially effective therapy to someone who needs it for bad psoriatic disease or bad spondylitis. Again, I think this is encouraging data about this particular side effect.
Yeah, I would love to see a study, I don't think it'll ever be done, where you gave AS patients, and maybe PSA patients as well, video capsule endoscopy or magnetic resonance enterography pre and post an IL-17 and a TNF. You know there's a very high incidence of abnormalities in both conditions. 30 to 40% will have subclinical Crohn's who have one perfect bowel movement a day. And I would love to see pre and post so that we would know and say, hey, maybe things look a little worse, but maybe they're not going to be clinically symptomatic. Because we don't know. Now we're looking for an outcome that's really very, very gross. You know, you say, well, have you had a lot of bloody diarrhea? And then you act on it. When people can have subclinical inflammation, we still could be missing.
Right. Next, you all are aware of a lot of guidelines about cancer. John's written about cancer. We've written ACR guidelines say you can give, someone has a solid tumor, you treat them as if they didn't have the solid tumor. So anybody who's concerned about skin, lung, prostate, colon, hygromas, whatever, and cancer, the ACR guidelines based on hundreds of thousands of patients say treat them as if they didn't have the cancer, meaning your job is to treat the arthritis. The big caveat or asterisk is, what about melanoma? And this comes from the data from the BSR-BR, looked at patients who had prior cancers. And on your left, you're looking at what happens to patients who had a prior malignancy who went on to receive a DMARD or TNF inhibitor, and you show the TNF inhibitor actually has less recurrence of the cancer. But when you break this down, on the very bottom two lines on the right, you can see those who had melanoma, there was a slightly higher rate of recurrence in melanoma. And they don't define melanoma here, whether these are in situs or invasives, but there is this concern about melanoma, and maybe you cannot use it in patients receiving TNF inhibitors or biologics. Well, to answer this question, the registries in Europe, specifically 9 registries from 11 countries, or 11 registries from 9 countries, looked at 130,000 patients and pooled their data. And this is the risk of developing an invasive melanoma, first melanoma, by going on a TNF inhibitor. By the way, they also showed the same data, not with the same power, for Rituximab and for tocilizumab and for abatacept, suggesting that, again, this should not be a concern with those biologics in this particular cancer. Now, again, they didn't test the the issue of recurrence in those with prior history.
I think with Brexit, doesn't have the UK registry have to withdraw from this now?
They do, that's right.
Okay, yeah.
So interesting studies at the ACR, a number of them addressing the issue of drug use in and around certain major surgery. The ACR had a special session, introduced its guidelines, which were largely expert-based, not based on a lot of evidence, suggesting that you can continue to take a TNF inhibitor and a DMARD and whatnot. Some of it comes from this sort of data. This data came from a VA study, I think done in centered in Seattle. Over 5,000 patients, 9,000 surgeries. Patients were either on or off their DMARDs or a TNF inhibitor, and they compared those outcomes to those that were on no therapy at all. 30% were on steroids. Half of them had comorbidities, and these are the outcomes. And it basically says it didn't matter whether you were on therapy or off therapy as far as infectious risk. If anything, the data trended towards having a lower infection risk, and that was defined 2 different ways. If you stayed on methotrexate, Plaquenil, leflunomide, a TNF inhibitor with or without any of those individual DMARDs. Do you believe this data?
Yeah, I think so. These data are, of course, incredibly hard to generate because you are left with the inherent confounding. If you have a patient and they have RA, but they also have diabetes, and it's an operation on the foot, and they are on a little bit of prednisone, you were so scared of perioperative infection, you're probably going to stop the TNF inhibitor way earlier than you would in someone who is robust, younger, healthier. So you'll never have a randomized study in this, and yet the lack of evidence didn't stop the ACR from making guidelines on this. And the guidelines, they said continue methotrexate, but stop the TNF inhibitor. So there's no, why did they do that?
We weren't on the committee. That's the answer to that.
Ed?
When you worry, you just mentioned it, you're worried about people who are the highest risk of infection, which is lower limb, diabetes, etc. So until you know the data on that high-risk population, I certainly wouldn't simply say, well, it looks okay, carry on with the TNF. I think in high-risk patients, until we know better, I think it's better not to use them.
Well, our patients are high risk, right? All right, but they're higher risk because you have them on multiple drugs. That's also, and you've further defined that. But what we do know from a number of very bad studies in the orthopedic world tell us that if you withdraw all therapy, patients flare, and inflammation drives risk way more than being on a foot surgery or being on drug. So flaring and inflammation drives risk way more. So you kind of want to be somewhere in between. You wouldn't want to be on high drugs, and you certainly don't want to be washed out, is what I would say. I think this kind of data supports that contention. I think you're right. I think that you can't just say the same for all orthopedic surgeries. They are definitely going to be, foot is absolutely the worst, right? Those are the ones you want to do. Let's quickly move on to a few more things. Biosimilars, a lot of action in biosimilars at these meetings. Here's a question for the audience. What factor will most influence you to not use a biosimilar in the next year? 1, paucity of information about their efficacy and safety. 2, insufficient cost savings or discounts. Number 3, extrapolating data from one disease to another based on very few studies. Number 4, unproven interchangeability. Number 5, loss of physician prescribing autonomy. Damn it. Number 6, many other biologic options to choose from. Answer now. 1. The one that upsets you most. The one that makes you say that D word.
Democrat?
So 2 and 4, insufficient cost savings. Way to step up.
Wow,
Number
that's the
4,
biggest.
and interchangeability. Again, we put a survey out on Room Now. It's going on just last 2 days. That the interchangeability was the single greatest issue for most people. There are 3 TNF inhibitors approved in the last year, these are on your doorstep. You got to use them. Already tell everybody about the Northwich.
So Northwich was eagerly awaited because it raised the question that we just had at our local VA. They said there's a biosimilar coming. We propose that all new starts, instead of getting the branded Infliximab, get the biosimilar Infliximab because it's 20% discount off the federal prices, which is already low. And then the next sentence was, oh, and by the way, we want to switch everybody else too. So I think most of us had been accepting of the idea for a biosimilar that we would start new people who we wanted to treat with the new one because it's approved. And if it's approved by a good regulatory agency, we should have trust that it's a good molecule. But the question is, well, if it's that much of a cost savings, and remember in Norway, they do it sort of funny. There's a winner-take-all tender system is what they call it. They've done this twice now, and after 2 rounds of this, the biosimilar for Infliximab, Remsima, or CTP13 is 60% cheaper than branded Infliximab is. So that's a lot of money. The government in Norway therefore did Northwich. Infliximab patients doing well with a variety of diseases, Crohn's, ulcerative colitis, rheumatoid arthritis, ankylosing spondylitis, psoriasis, psoriatic arthritis, randomized to either continue the originator or to transition to CTP13. Followed for a year, the outcome was defined as worsening of disease according to criteria within the disease. So in RA and PSA, it's peripheral joint arthritis with the DAS. For psoriasis, it's the PASI. For Crohn's, it was a modification of the Mayo criteria. And what they decided was they were going to pool them all. And it was powered to group all of those diseases together. Bottom line, and you see in the black, is that it was not inferior. So you'd say, well, there's no reason not to switch your patient from the originator to the biosimilar. Individual diseases, particularly Crohn's, as you see up top, which is a little bit noteworthy because they had the largest number of patients. Here, just barely it was just barely not, or even going to where it was inferior to the Infliximab. not for ulcerative colitis. And they had other outcomes which are not part of this. They had fecal calprotectin, which is a good biomarker in Crohn's. They had some other ways of assessing Crohn's disease activity, which were also much more straight in the middle when you talk to the statisticians about this. So although and it's not powered for this, so this was sort of something they decided to do as they were getting into the study, and they stopped the study a little bit earlier. You see here, it was planned for 500 patients. They got to 481. The reason they stopped was that once the price went from 30 to 60% lower, they said they couldn't get patients anymore. Everybody said, that's it. We're in. We're going to we don't care. We're going to go ahead and switch. So the data are the data. I would like to ask the audience, and is this data to support your view of, yes, we can totally switch someone on originator 2 biosimilar, or does it say, heck, I'm concerned, look at those data there? And maybe, Jack, you want to pull up the results of the survey? Or?
Yeah, we asked that question, and at least a lot of people are worried about extrapolating data. Only about 20% say extrapolation is fine by me. Other people have some degree, up to 70% of people have some degree of concern about extrapolation, but that's the case. You get, studies being approved in psoriasis for Erelzi, but you get the other 6 indications for all the etanercept indications, just with doing the psoriasis trial.